Hello guys, Krishna here. A warm welcome to all of you to yet another recall questions discussion. And here it is about the recently concluded INI-CET November 23 Physiology recall questions. As far as physiology questions are concerned, questions were largely from the previous year topics. If you are thorough, many questions you can definitely answer in physiology, except one question. Always in INI-CET, one question from all the subjects comes from out of nowhere. So it's a brand new question. So we'll discuss all the questions here. I will ask you a few questions. You try to answer them in a way it will be beneficial for both of us. Shall we start the session now? I'll put the questions now. The first question from the very familiar area. What is that question, sir? What is the mechanism by which the calcium levels are increased by parathyroid? Just look, think and answer. Increase osteoclast activity, along with that reduced excretion from kidney, release of calcium from osteoblast, increase osteoblast activity. The answer for the question is obvious. Remember, it is option B. Increase osteoclast activity and reduced excretion from kidney. So in a hurry, if you look into this question, if you look only into the option A, increase osteoclast activity, you may go for that answer, but don't do that. Always try to read all the four options. So definitely you can see in option B, along with increase osteoclast activity, there is reduced excretion from kidney. That is the best answer. Now, the discussion, very important discussion. Try to answer these few simple questions I'm going to ask you. What about this parathyroid, sir? What is the source? Obviously, we know from an important gland which is shown in the picture. And what is that gland, sir? That is our parathyroid gland. Is the source for parathyroid. Second question, which cells? All were previously asked questions. The cells from here are called as chief cells. They are the source of our parathyroid. Next, what type of hormone is this? Is it a steroid hormone? Is it a vitamin derivative? Is it a protein hormone? Yes, it is a classical example for a protein hormone. Protein means combination of amino acids, right? Number of amino acids, very familiar question. Physiology and orthopedics. Always remember in its structure you see 84 amino acids. What is the importance, sir? Why I am stressing physiology and orthopedics? Out of this 84 amino acids, the first 34, remember 1 to 34. The first 34 amino acids we take and make it as a drug form of parathyroid. What is the name given to this recombinant drug form of parathyroid? The answer is very simple. The name of the drug is teriparatide. I think you are clear. It is about the parathyroid, protein hormone, 84 amino acids, 1 to 34, recombinant drug form of parathyroid, teriparatide. Now, this question is specifically about the actions. So, actions of parathyroid. It is always about the 3 hormone, 3 organ system, right? One hormone here is parathyroid. It will definitely act on 3 organs. What are those 3 organs? Yes, you are correct. Tell me. Obviously, bone, kidney, intestine. Which is most important, sir? Bone. I always say, bone is considered to be the bank for calcium. If you have excess, deposit in the bank. If you are in debt, if you need calcium, take from the bank. That is bone. So first we are going to discuss about the bone actions. Very, very simple, guys. In bone, parathyroid is definitely going to cause bone resorption. Excellent. Bone resorption. What is the mechanism? It is this mechanism they usually target the MCQs into. Listen very carefully. If they ask you where the parathyroid receptors are found, the parathyroid receptors are found exclusively in the cell blast. It is found in osteoblast. When parathyroid act here, this osteoblast under the influence of parathyroid secrete an important agent, and that agent is called as rank ligand. It is this rank ligand, listen to the words carefully, going to induce the differentiation of this important cell, that is our osteoclast. When osteoclasts are differentiated, they will perform their function effectively. And what is that function, sir? That is our bone resorption. This is one important mechanism to increase calcium levels. Excellent. In-bone parathormone bone resorption mechanism. Parathormone receptors are in blast. Under the influence of parathormone, osteoblast secretes rank ligand. Rank ligand induces differentiation of osteoclast, eventually leading to bone resorption. So there is increase in calcium. It is about bone. What about kidney, sir? A very, very important action. The actions in kidney, very simple. It increases calcium reabsorption by exclusively acting at the level of DCT. Okay? In kidneys, parathormone increases calcium reabsorption, that is calcium conserving. You can also say it reduces the excretion of calcium. Totally, it is calcium conserving, parathormone in kidney. One more important action, it increases, remember guys, very critical point, phosphate excretion. Parathormone is going to cause phosphate excretion. This is why I always say PTH, phosphate terminating hormone. It is going to cause phosphate excretion. How, sir? A very important mechanism. It was also asked before. This is exclusively at the level of PCT. Okay? From the distal tubules, calcium reabsorption. From the proximal tubules, parathormone causes phosphate excretion. What is the mechanism? An important channel protein we call sodium phosphate cotransporter. Where is this found, sir? Proximal convoluted tubule. Remember, this channel protein is inhibited by parathormone, eventually leading to phosphate excretion. This is one important channel present in PCT for sodium and phosphate reabsorption. Parathormone is inhibiting this channel protein, thereby causing phosphate excretion. So this phosphate excretion, phosphate terminating hormone. I will ask you a simple question. A hormone that decreases calcium is called calcitonin. Yes, sir. In the same token, you can say a hormone that decreases serum phosphate levels. Which hormone is decreasing serum phosphate levels? Our parathormone. Decreasing phosphate levels. That is why this is called phosphatonin. Decreasing calcium means calcitonin. Decreasing phosphate in serum means phosphatonin. Which is the physiological phosphatonin? The answer is parathormone. So parathormone is causing phosphate excretion. It also causes reduced calcium excretion. That is why the answer. It increases osteoclast reabsorption and also calcium conserving, parathormone. Parathormone also causes phosphate excretion. So two important organs over. Bone, kidney. What about intestine, sir? Parathormone action in intestine is largely indirect. That means what, sir? From the intestine, parathormone increases vitamin D levels. Vitamin D, rule of thumb, it is the only calcium regulating hormone that can act in intestine. No other hormone can act in intestine. Calcium, intestine, vitamin D. So with the help of vitamin D, it increases calcium absorption. That's all. So all these actions eventually going to increase serum calcium levels but decrease serum phosphate levels. That is the action of parathormone. So intestine, it is indirect. Parathormone increases vitamin D. It is this vitamin D that increases calcium absorption. So this is a very important area. Parathormone, its nature, its chemical structure, the drug form and its actions on the three important regions are very important. Now, Next question. The upstroke of action potential, that is phase 0, in the SA node is due to. Look into the options. They interchanged sodium, potassium, calcium, all these three names. They mingled and give some options. So I think in every session they are actually alternating between these two action potential. In the previous session it was about ventricular action potential. Now in this session it is about the SA nodal action potential. That means these two potentials are very, very important. Here it is about the SA nodal potential. The answer for the question phase 0 exclusively because of calcium currents only. Why sir? I thought you already in the main videos, revision videos everywhere. SA node is also considered to be the pacemaker. This SA nodal potential, three important phases guys. We have phase 4, yes. We have phase 0. We have phase 3. Phase 4, phase 0, phase 3. What are the names given to them, sir? Phase 4 is called as prepotential, which is also called as pacemaker potential. Phase 0, the one they asked in this question, depolarization. Phase 3, the opposite process, repolarization. What are the ions responsible, sir? Knowing this will help us to devise certain drugs for treatment. So you need to know this. This phase 4, prepotential, first and foremost, one important ion comes here, that is calcium. It is a transient phenomenon. It is carried through a T-type calcium current. First cause for phase 4. The second important cause for phase 4. What is that? What is funny here? There is something called as funny currents. These funny currents are a special type of sodium currents. So there are two causes I told you for prepotential. Transient calcium influx, funny current sodium influx. There's a third cause also, I will tell you soon. What about this 0, sir? Depolarization. Exclusively solely because of calcium coming inside. It is exclusively through long-lasting calcium currents. So phase 0 depolarization, calcium influx, long-lasting L-type calcium currents. Prepotential, T-type calcium. Depolarization, long-lasting L-type calcium currents. What about repolarizations are always because of potassium ions moving outside? Potassium efflux we call. Repolarization, potassium efflux. We are left with only one last cause for prepotential. What is that, sir? We can clearly see potassium ions are moving out. Potassium ions are moving out. We are getting repolarization. At one point, there will be decrease. Listen very carefully. There will be decrease in potassium that is moving out. If potassium keeps on moving out, you will get repolarization. If there is a decrease in potassium moving out, automatically you will get phase 4 here. So the third important cause, that means the third cause for prepotential is decrease in potassium efflux. That's all. Now please help me revise along with me. Prepotential, three causes. T-type calcium, funny current sodium, decrease in potassium efflux. Depolarization, solely by L-type calcium currents. Repolarization, potassium moving out, potassium efflux. That's all. This is about SA nodal potential. What about the next question, sir? In the given cross-section of a muscle spindle, the structure marked below is innervated by which of the following motor nerve fibers? And where is the arrow mark, sir? Are you clearly seeing, friends? Here. What is this fiber? Remember, these fibers are our very well known intrafusal fibers. They are actually innervated by gamma motor neuron. So the answer is option A, gamma. What is the discussion, sir? Very, very simple. What is the structure? Muscle spindle, one of the most favorite topic for all examiners, no matter what. Definitely they will set a question from muscle spindle. This muscle spindle is very much important for stretch reflex. What is stretch reflex, sir? Simple. When you stretch any muscle, that muscle will contract for you. The stretch-induced contraction is our stretch reflex. Commonly, we do our very well-known knee jerk with the help of a knee hammer. Classical example for a stretch reflex. To understand the muscle structure here, this is our very well-known skeletal muscle. It is having two types of fibers, my dear friends. The first type of muscle fibers which is visible outside, we call them as extrafusal fibers. True. The one that is buried inside, remember, they are our very well known intrafusal fibers. Present outside extrafusal, present inside intrafusal. This intrafusal is my muscle spindle. Then what is this extrafusal, sir? This extrafusal are our actin and myosin. Never forget. Extrafusal fibers are actin and myosin. Intrafusal fibers are muscle spindles. This muscle spindle play a role in stretch reflex. If you look into this intrafusal fiber muscle spindle, this is my muscle spindle. It has got two ends. It is having a central end. It is also having two peripheral ends. It is this central portion you see the receptor part. It is in the peripheral region you see innervation. Are you seeing the one in the blue color, innervation? What is this innervation, sir? This is my gamma motor neuron. That means intrafusal fibers, muscle spindles, the peripheral ends are innervated by gamma motor neuron. On the other hand, extrafusal fibers, actin and myosin, they are classically innervated by a motor nerve, that is my alpha motor neuron. Extrafusal fibers are innervated by alpha motor neuron. Intrafusal fibers are innervated by gamma motor neuron. Actin and myosin innervated by alpha motor neuron. Muscle spindles, the peripheral contractile ends are innervated by gamma motor neuron. So this question answer is very simple. Intrafusal fibers means muscle spindles, gamma motor neuron. Right guys. Now the next question. What is incorrect regarding the baroreceptors in the carotid sinus? Baroreceptors. They need the support of some transducers, express certain channels. They are the branches from, they are innervated by the branches from glossopharyngeal nerve. Pressure sensors are deep in the smooth muscle layer. If you look very carefully guys, SA nodal potential, ventricular action potential, baroreflex, these are some important area, nerve action potential. Invariably, 100% question definitely going to come. These are some important area you should never ever miss. Now this is about baroreceptors and baroreflex. Last session also they asked one question from baroreflex, right? Now, this is correct. This is correct. This is correct. We all know. Except pressure sensors are deep in the smooth muscle layer. No. They are present in the adventitial layer. Remember, they are exclusively present in the adventitial layer. They are not deep. They are found in the adventitial layer. So what is the discussion, guys? Very simple. What is the answer for the question is D, the discussion. What are these baroreceptors? Where are they found? The first one is obviously called carotid sinus. You see them as a small dilation where? In the internal carotid artery. Yes, internal carotid artery, carotid sinus. In the arch, aorta, aortic arch. These two are the baroreceptors. What type of receptors are they? They are pressure sensing receptors which are going to sense mainly increase in blood pressure. That means this increase in blood pressure is going to stretch the air walls. So what type of receptors are they? My dear friends, they are stretch receptors. This stretch is going to open certain channels. And what are these channels, sir? Certain stretch sensitive channels which are none other but our TRP group of channels. which are transient receptor potential channels. Correct? They have some transducers which contain certain channels, stretch sensitive channels, TRP channels. Now, most important MC. This carotid sinus is obviously innervated by our cranial nerve 9, glossopharyngeal. Which important branch, sir? We call that as Herring's nerve. Yes. Aortic arch will be innervated by cranial nerve 10, vagus. Which special branch, sir? We know it is the Sion's nerve. Glossopharyngeal branch is Herring's nerve. Vagal branch is Sion's nerve. They are going to innervate our baroreceptors. In response to increase in blood pressure, our baroreceptors are activated. They are going to activate an important reflex, and that reflex is the baroreflex, whose primary objective is to decrease that blood pressure. Not only that, it also, as a part of this reflex, decrease in heart rate. So increase in blood pressure because of baroreflex, decrease in blood pressure, decrease in heart rate. So increase is followed by a decrease. It's a classical example for a negative feedback control system, blood pressure regulation. All these were asked before, you know very well. So baroreceptors, very high yield area. They are present in the adventitial layer. They are not deep. That is the discussion. Next. Look who is here. Our very well-known, very familiar person. This is about the nerve action potential. Now I told you. Which of the following is responsible for the phase marked C to D in the graph? See, C to D. Very easy scoring area. The C to D is obviously our repolarization, RE. Repolarization. Repolarization means potassium efflux. Now, look into this diagram, guys. By this time, you must be very familiar. Who will answer correctly? What is this point A? This point A is considered to be the threshold. Yes, sir. Which is also called as firing level. True. How much is that value? Minus 55 millivolt. The threshold is usually minus 55 millivolt, 55. Minus 55 millivolt, it is nerve action potential, remember. Once the threshold is reached, action potential will fire. What is this B, sir? This B is our depolarization, which is exclusively because of sodium ions coming inside, sodium influx. A quick flashback. SA nodal potential depolarization was due to calcium influx. Nerve action potential depolarization is due to sodium influx. What about this point C to D, sir? Obviously, it is our repolarization. Repolarization means potassium ions will move out. The reason is potassium efflux. What about this E, sir? It is also another high yield repeat area. Mainly in nerve action potential, you see this phase is the hyperpolarization. Because this potassium channel is responsible for repolarization, they close very slowly. There is still continued potassium efflux. The cause for this is also the same potassium efflux because this potassium channels close very slowly. Potassium ions are still moving out. The RMP becomes more negative. We call this as hyperpolarization. And also remember, it can be also because of chloride ion, a negatively charged ion that is coming inside. Both this continued potassium efflux and chloride influx are causes for hyperpolarization, which is actually done by this important neurotransmitter GABA. GABA influences this hyperpolarization. The causes for hyperpolarization: continued potassium efflux and chloride influx. So in the graph, they asked from C to D, that is my repolarization. Potassium efflux should be the answer. Very familiar repeat topic. Next question. Which sodium transporters are present maximally in the early part of the PCT? So 4 are there: sodium potassium ATPase, sodium glucose co-transporter, sodium hydrogen antiporter, sodium bicarbonate symporter. What do you think? out of this 4, the first 3 you see. So the answer for the question is 1, 2 and 3. A very important discussion, guys. The answer is option B here. Look very carefully. Proximal tubule sodium reabsorption. Remember, usually 70% of sodium reabsorption happens here. Equal amount of water reabsorption also happens here, the same 70%. So equal amounts of sodium and water are reabsorbed here in PCT, 70%. Remember, 5 important channel proteins are here. What are all they? This is number 1, we will see. This is second channel protein. This is the third channel protein. This is the fourth one. We will name them. First numbering them. This is the fifth one. What is number 1, sir? Any idea? Any guess? The arrow marks are in opposite direction. This is our very well known sodium hydrogen exchanger. This is the major channel protein for sodium reabsorption in PCT. Most important. Sodium hydrogen exchanger. What about second, sir? Physiology, pharmacology, general medicine, diabetology. Very important. The arrow marks are in the same direction. This is about a co-transporter which is sodium glucose co-transporter. They are our SGLT2. Third, what is this third, sir? The first question we discussed. This is the sodium phosphate co-transport. What is fourth one, sir? This is sodium reabsorbed along with amino acids. We call sodium amino acid co-transporter. That means sodium is coming inside the cell by lot of ways. Sodium is coming inside the cell through lot of ways. How to send this sodium into the blood vessel? For that, a very important channel protein, that is our sodium potassium ATPase. What is this fifth one, sir? Our very well known sodium potassium pump. That's all. All this you see mainly in the early parts of PCT. What are all the ones? Sodium hydrogen exchanger, sodium glucose co-transporter, sodium phosphate co-transporter, sodium amino acids co-transporter. To send all this sodium from cell into the blood vessel, we need sodium potassium ATPase. So 70% of sodium and water are reabsorbed in our proximal convoluted tubule. Very practical question, most clinical, most practical out of all the questions asked. Very simple question also. Which of the following is responsible for bradycardia following CO2 insufflation during laparoscopic surgery? Is it because of any injury or any embolism or a peritoneal stretch or a decreased afterload? The answer is definitely peritoneal stretch, no doubt. It is C, peritoneal stretch. Nowadays, it is a very common thing. Laparoscopic surgeries, look into this diagram. We do carbon dioxide insufflation mainly to create, why? To create pneumoperitoneum. So there is a possibility here, this distension, peritoneal distension leading to peritoneal stretch, which can activate a cranial nerve, which is our vagus, leading to vagal reaction. One important manifestation of this vagal activation, decrease in heart rate. That is what we see as bradycardia. If you see bradycardia, you have to act immediately. What is the management here, sir? Simple. We are doing insufflation. We are seeing bradycardia. The opposite of insufflation is quickly desufflate. That's all. Desufflation. It is the vagal activation. So we can definitely use for management here a vagolytic like atropine, for example. And finally, a very important preventive measure, limiting intra-abdominal pressure below 12 to 15 millimeters of mercury helps to prevent this bradycardia. So if you see bradycardia, how to manage? Desufflate, give some vagolytic, or try to limit the intra-abdominal pressure below 12 to 15 millimeters of mercury during this procedure. A practical question. Yes. Next question. Look who is here. Glucose transporters. Insulin independent glucose transporter. is present in all of the following except the history of this glucose transporters appearing in entrance exams dates very long back. Since antiquity, since the entrance examination started, you always see every year a question from glucose transporter. If you see this question, you have to be very happy. Certain things, certain people, right? For example, our Mahendra Singh Dhoni, when you see him, you are always cheerful. Like that, this glucose transporter also, it is coming to give you mark. You can easily score in this. Salute to these glucose transporters. They will never disappoint you. Insulin independent glucose transporter is present in all of the following except. That means which is insulin dependent here. Definitely adipose tissue. Very simple question. It is D. Now look into the discussion. Accents of insulin. Which important glucose transporters are? It is GLUT4. True. What are all the insulin dependent regions where insulin is going to incorporate this GLUT4? Three important regions, friends. The first one is obviously our heart. True. Second one is this muscle, that is our skeletal muscle. Third one is the answer. What is that? Adipose tissue. Insulin is going to incorporate GLUT4 here. Look very carefully. This is our glucose transporter 4. So from the blood, all the glucose will be now moved inside heart. From the blood, glucose is moving inside skeletal muscle. From the blood, glucose is moving into adipose tissue, thereby decreasing blood glucose levels. So what type of transport process is this? Remember, it is a classical example for a facilitated diffusion. Glucose transporters, very good friends of us, glucose transporters, facilitated diffusion. Insulin dependent regions are heart, skeletal muscle, adipose tissue. Which glucose transporter? GLUT4. And finally, one more question, which is actually a brand new question. What is that question, sir? Which of the following pain stimulus is associated with carrageenan-induced experimental pain model? What is this model? This is a new question. So you need to understand the discussion here, which is actually new to most of us. The answer for the question, this model is useful to study inflammatory pain. So the answer is C. So any new topic, you have to be thorough. What all the points you need to remember here? First question comes into our mind. What is this carrageenan, sir? This is the picture. This carrageenan is none other but a type of polysaccharide we obtain from red seaweed. Simple. It is a type of polysaccharide, that's all. We commonly use this in processed food. It's useful as a thickening agent. This carrageenan, that's all. Very simple use. In processed foods, you find carrageenan. It is a thickening agent. What is the source? Red seaweed. What is the nature? Polysaccharide. What are we going to do, sir? This carrageenan we are going to inject especially into this animal. Where? At the level of its paw. Look very carefully. We will inject this in the paw. That's what I'm going to tell you now. This carrageenan is injected into rat paw. There is a polysaccharide here. Physiology and microbiology. So after this injection, this carrageenan is going to activate complement system. When complement system is activated, you may get a full-blown inflammation. That is why inflammatory model. What is the time sequence, sir, after injection? This inflammation peaks 3 to 5 hours after injection and it subsides in 1 day, 24 hours. That's all. So after injection, 3 to 5 hours after injection, the inflammatory response peaks. 3 to 5 hours after injection, it subsides in 1 day. So what is this model called as, sir? Carrageenan-induced paw edema model. So carrageenan is injected into the rat paw. You will get inflammation because of complement activation. This inflammation peaks 3 to 5 hours after injection and subsides in 1 day. So this inflammation has got two important parts. The initial part, if they ask you, can be because of histamine Yes, sir. Can be because of serotonin? Yes, sir. Can be because of bradykinin? Yes. The initial part of the inflammation because of carrageenan is brought about by certain acute phase chemicals like histamine, serotonin, bradykinin. What about the later part, sir? That means after 3 hours. The inflammatory changes you see after 3 hours, the later part of inflammation is because of prostaglandins. So all this you can study. With the help of this model, inflammation and its subsequent responses, which mediators are responsible. So this inflammatory pain model is this carrageenan model. So the initial part of inflammation is because of histamine, serotonin, bradykinin. The later part of this inflammation is brought about by our prostaglandins. So these are the questions actually we got in the recently concluded INI-CET physiology questions. As you can see, very familiar areas, nerve action potentials, cardiac action potentials, our veteran glucose transporters, all this definitely are going to get repeat topics. So be thorough with these topics, dear. My good luck and best wishes are always there for you. Good luck, guys. Thank you so much.